Assalamualaikum and very good morning, everyone. Welcome and thank you for joining our webinar program for today. My name is Badr Hisham Abdul Rahman and I'm the moderator for today. This program will last about 1 hour. We are lucky to have three world leader in vaccine to join us for today. The title of our webinar is The Needs and Benefits of the COVID-19 Vaccine for Children and Booster Doses for Adults. Yeah. In pandemic COVID-19 that started in March 2020, that now we have a solution. Most of the population have been vaccinated. I'm speaking about global and mostly about Malaysia. And but now we're getting back into a normal life. But the virus is still around us. Yeah, even though for Malaysia, total infection up to date about 4.73 million, with a death of 36,000. But most of the population been vaccinated, with a statistic of first dose about 86%. Those who received second dose 84%. Almost 50% of Malaysian population receive booster dose. But the second booster dose is something that a topic of the people. But apparently in Malaysia, the numbers who actually receive second booster dose only stand at 1.3%, which is very low. And the infection is still real. And even today in Malaysia, the average infection is about 4,200 cases. We had post a very successful vaccination in 2021. Between January to May 2022, there's a surge in infection where it even peaked at 30,000 cases per day. Now the question is whether we should get another booster to protect ourselves, because Omicron is still rampant, infecting everybody around us, and we know they are still mutating. Yeah. So what do we do, especially certain target population, the elderly, the comorbid, the children, because the disease burden is still very, very high. So we're lucky to have three panelists for today to share the latest updates on COVID-19 pandemic, and also the clinical data related to the booster dose, and also the usage and approval both at WHO and also in Malaysia. So I would like to introduce the first panel, none other than our vaccine expert in-house from Maniaga, Dr. Ajit Pal Singh. He's a medical doctor by training, originally from India, with vast experience globally. He was trained in the USA, worked with the United Nations for several years on vaccination program. He'll be the first speaker giving an insight about COVID-19 pandemic and current issues in Malaysia. The second panel will be across the globe, all the way from Chile, Dr. Rafael Arauz. He's also a medical doctor by training. Currently, he's a chief epidemiologist and head of epidemiology at Department of Health, Ministry of Health, Chile. And he's very active in COVID-19 pandemic management. He has two major publications to share, also maybe today, still working, collecting some data, but two publications at Nature Medicine and also at Lancet. So we'd like to hear more from Dr. Rafael. And then our third speaker will be Dr. Young Jun Gao. He's also another medical doctor and vaccine expert. He's currently the Medical Affairs Director at Sinovac Biotech Limited, Beijing, China. He was also trained in USA and various parts of Europe. And prior to Sinovac, he had several positions at multinational companies in China. So I would like to welcome all three panels to the program. And I think we'll begin with Dr. Ajit.
Thank you, Dr. Bud.
Thank you.
Okay, thanks, Dr. Bud. Welcome to all the members who have joined us this morning via Zoom link. So I have a few slides to present first, and then we will go into a panel discussion later after all speakers have presented their slides. I will be covering majorly the COVID vaccine issues in Malaysia, what we have done so far, what are the gaps, and what is the way ahead for us. Can I have the slides? Okay, next slide. Okay, just to give the perspective of this current catastrophe of COVID-19 in Malaysia and globally, we have passed the Spanish flu total number of deaths reported during that period. There was a paper published in early 2007 in UK, which indicated roughly 1% of population was infected severely, around 34,000 deaths. For the COVID-19 in 2021-22, we already have 36,000 plus deaths, and it's still continuing. So this probably is one of the worst catastrophes Malaysia has seen. If you look at the deaths from tsunami, the emergency in 1948, 1960, and the World War II, I mean, this is one of the major catastrophe which where a lot of civilian or general population have suffered. Next slide. Dr. Budd has just emphasized that we had COVID cases started coming from March of 2020, and there are majorly two peaks which we have seen so far. The first peak, which happened from July of 2021 until November 2021, which was majorly due to Delta variant. And this was successfully controlled through vaccination program, which started somewhere around March, April in Malaysia in 2021. Which was still continued, and we have vaccinated around 72 million doses. But instead of this vaccination ongoing, we have seen a big surge earlier this year, starting January, February, and this was mainly due to Omicron variant, which has a major changes in the spike protein of SARS coronavirus 2 virus. These changes in the virus spike protein made it more infectious, and hence the number of cases are going very high. Again, we are now seeing a surge in the cases starting late July this year, which is mainly because of sublineage BA5, which has now replaced the other lineage of Omicron, BA1, BA2, and all those. And this lineage is, I will talk a little bit more about BA5, what are its characteristics. Probably in the next slide, but this lineage has now replaced the earlier lineage of Omicron globally as well as in Malaysia. Almost 80% of the cases now are because of BA5. Next slide. So this BA5 is there are multiple mutations in spike protein, and what it has done, it has increased the binding capability of virus to ACE2 receptors, and hence the reproduction rate or R0 factors has increased 3 to 4 times or even 6 times from the ancestral COVID virus. If you look at the ancestral virus, the Wuhan strain, the RO was 2.5, whereas for Omicron B5 lineage, it can go all high as 15. Just to translate in layman language, R1 means that one person can infect one person, and in case of R1, the infection will remain in the society, which is like hepatitis C and Ebola. So one person infecting one person, and there is a continuous infection in the society, but is not showing any increase. R less than 1 indicates that the infection is dying, but anything more than 1 indicates how many people can be infected by one infected person. And this R15, 18 to 15 for BA5 is equivalent to mumps and measles, which are very, very infectious. However, one good thing has happened because of these changes in the spike protein. The fusogenicity or the cell membrane fusion capability of virus has reduced, making it less pathogenic. So we are seeing minor, not so severe cases anymore, but there's a shift in the pathogenicity of disease. This also reflected in the symptoms. Now the cases which are coming have more like abdominal pain, fever, sore throat, and muscle ache. And we don't see any more loss of smell and taste, which was seen with earlier variants of COVID virus. From the immunology point of view, the immunity generated by the infection of earlier variants is no longer protected against the new Omicron. And the immunogenicity generated by the primary series of virus is also reduced. So this Omicron, especially BA.5 and 4, they are going to evade the immune response generated by either infection in the past or the primary series of vaccines, which is probably all the vaccines available so far. Next slide. This was also demonstrated in one of the study which was done by Washington University in collaboration with Harvard Medical School. And as you can see in this graph, they have checked the neutralizing antibody response for all the vaccines available, around 6 of them, which is mRNA, subunit, adenovirus, as well as kill, against different variants of COVID virus. And if you pick up any color graph, let's say we pick up for the green one, or no, the red one for mRNA vaccine, for BA.1, the antibody titers were very high. But if you look at the last bar, which is for BA.4 and 5, it has substantially reduced, very close to the threshold of protection. And similar reduction has happened for almost all the vaccines when they were given as primary immunization as 2-dose initially. Next slide. However, in the similar study, when they give a booster, the booster restores neutralizing potency against Omicron, almost all Omicron sublineage, including BA.4 and 5, to the previous level as which was seen for other variants. So if you look at the same graph, the green one for mRNA, when you boost it with the first booster, the neutralizing antibody response became as high as the one which was seen earlier for Wuhan variant much earlier in the disease epidemic. So this data suggests that a booster is definitely needed for Omicron, BA.4 and 5, which are now currently circulating in the population. However, this study did only tested Pfizer as a booster and mainly AstraZeneca virus as a booster given after different vaccine regimes. Next slide. But in first ever head-to-head study where homologous booster and a heterologous booster were tested for Sinovac recipients in Malaysia. This study was conducted by researchers at ICR in Malaysia, and this was published only last week. This is a very large study. They have taken 13 million vaccinees into the study. And out of this 13 million vaccination, the population was divided among people who have received 3 doses of mRNA vaccine, 2 doses of CoronaVac, followed by a mRNA booster, and 2 doses of CoronaVac, followed by CoronaVac booster. And what the study results indicated, that definitely there's a need of booster after primary Sinovac vaccine. We know that this is required for all the vaccines. But when you boost Sinovac vaccine recipients with Pfizer or Sinovac, there is no difference in protection against symptomatic disease. And even when you divide the population by age group, young adult, middle age, and elderly, we still see that there's not much difference between the protection, indicating that a heterologous or a homologous boost after Sinovac primary recipient behaves same in terms of protection against symptomatic disease. And this is a very interesting paper. First time globally head-to-head comparison was done for a booster vaccine between mRNA and a kill vaccine, indicating that homologous boost for Sinovac is as good as heterologous boost. Next slide. In another study, we know safety is a big concern when it comes to the booster, and people are not going for booster vaccines. One reason could be because of safety. And in this study, which compared head-to-head between 3 different vaccine types, kill vaccine, a viral vector, and an mRNA, all the vaccines showed in Thailand, they are within the safe and acceptable profile of safety. However, the kill vaccine booster has the least adverse events, which was reported in that study. Next slide. This is the situation of vaccine in adults in Malaysia. If you see adults, they are almost 90, 99, 98% vaccinated for first dose, second dose, but there is still a big gap between the first booster. It's around 30% of the population, or around 7 to 8 million of the population has still not taken the first booster, who were vaccinated with primary series. Same is reflected in elderly population, which is around 30% of the population who has taken primary series has not taken a booster dose. Malaysia has recently started using second booster in special population, but we are still worried that this the first booster, the population which has not taken first booster should be encouraged to take booster as soon as possible. Next slide. Now, the take-home message from adult vaccination that for your consideration, how serious is BA5 infection and how dangerous it is. We know BA5 is now dominating. It's around 80 to 90%, and the recent surge, which we are seeing close to 4,000 infections per day, and it's still increasing, is because of BA5. But the impact is less because the disease is less severe. What is our risk to get infected or reinfected, especially elderly, immunocompromised? I think it's very certain that we will get infected because previous immunity or primary vaccination immunity may not be able to protect us unless we have taken a booster dose. And what should be the timing for a booster dose? It should be anytime after 3 to 6 months of the primary vaccination series, but earlier you take it, better it is. Now we move to COVID-19 challenges in children. We know with the change of this variant from Delta to Omicron, we have also seen a shift in the disease pattern in children. And now we have seen increased susceptibility to the children because of this increased transmissibility of the virus. The issue is that now the children are actually the household is getting affected. You know, if there's an immunity gap in the household, the people who have not taken the booster dose, there's a gap in the immunity, and the infection is now not coming as an individual, but is being reported as household globally. So it's not just there's one member of the family affected. Now it's probably 80% or 90% of the complete family gets infected if one of them gets infected. This is due to the high transmissibility of the virus. Also, the social restrictions, social movement restrictions in the community have also increased the transmissibility. And this multi-organ inflammatory syndrome in children is a real threat because once the infection increase, and because of this Omicron, we are seeing increase in infection. Usually MIS is reported 1 per 32,000 infection. And this is a hyperinflammation of organs in children, which usually comes after 4 to 6 weeks of primary infection. And it involves multiple organs of a child, including heart, lung, skin, kidney, mainly present with fever, myalgia, but there could be headache and chest pain, breathlessness, and this kind of infection is very difficult to manage. This will create a nightmare for a pediatrician in hospital to manage MIS, specifically in children. Next slide. This is the graph which showing that the pediatric cases admission in one of the hospital here in Malaysia, it has started to show increase. We know that the category 1, the asymptomatic cases are less, but the category 3 and 4 cases have shown a steep rise. And in one of the hospital here in KL, reported close to 90% increase in inpatient pediatric population, especially 0 to 11 years of age. Next slide. This infographic was published by US CDC, which states that the children who are infected with COVID-19, 3 of them have no underlying condition. They're non-COVID, they're non-obese, they have no other type condition, and they get infected. And 9 out of the 10 children who are infected with COVID-19, they are unvaccinated. And every 10 infection, 2 may need ICU, and every 32,000 infection, 1 may end up in MIS. Next slide. So with this and the objective in mind, Malaysian government started PICS Kid vaccination program to protect children from COVID-19 illness and mortality. so that to allow schools to run and continue and control infection during the schooling, and to increase COVID-19 vaccination coverage among population in Malaysia and to create awareness. This vaccination probably started earlier this year as called PICS-KID. Next slide. However, we have seen there was a good uptake of vaccine in adolescent, which is 12 years and above, but between children between 5 to 11, the pickup of this or acceptability of this vaccination program is close to 50%. We have not seen the acceptance of vaccination as much as we have seen in adults in Malaysia. This is probably because of majorly the cases are mild and people are not aware of the complications. Next slide. Now, in order to boost this PICS vaccination program for kids, Malaysian government has allowed vaccination of kids in private clinic. And as you can see in the infographic on the left, Sinovac vaccine can be taken and given to kids at a cost of 77 ringgit per dose at private clinics which are near you. Of course, earlier the Pfizer vaccine was given as free of cost during PICS-KID program, which was supported by SPPV program in Malaysia. Take-home message for children. Most of the cases are Omicron in children, but they are mild. Now we are seeing atypical symptoms in children, which include seizures, sore throat, abdominal pain, which was not seen earlier in other variants of COVID. We have to home quarantine if a child gets infected and should be aware of the symptoms like dehydration, respiratory distress, seizures, lethargy, poor consciousness, vomiting, diarrhea, abdominal pain, and inability to take food. We need to ramp up PICS-KID program for Malaysia. Definitely this vaccination rate has to reach around 80 or 90% of children between this 5 to 11 to be vaccinated. And we want to encourage the families for this children vaccination. Please find out a vaccination center near you, either private or government, and get them vaccinated as early as possible. Thank you. That's my last slide. Dr. Bhatt, over to you.
Thank you so much, Dr. Ajit. Very interesting facts and data about the requirement for vaccination. I believe you have given some insight on the real issue why some adults of certain age group are quite hesitant to take the booster dose now, also among the children. So you have addressed issues related to the safety, maybe the concern on the efficacy. So I believe members of media and scientific community in the audience have more questions. Please type in your question and we'll address that later after we completed all three speakers' presentation. So we move on to the next speaker, Dr. Raphael. Over to you, Dr. Raphael.
Okay, thank you very much. And good morning to everyone in Malaysia. Here is the night, and I'm super happy to be here. And thank you for inviting me to present and to share our experience vaccinating people during the COVID pandemic. Just a quick clarification. I used to be the chief epidemiologist at the Ministry of Health. I continue to work with them as an advisor, but it is fair to say that I am not the chief epidemiologist today. Having said that, I'm going to focus on the assessments that we've done to all the interventions that we have implemented in Chile, and the idea is to show you some data that helped us to decide whether to go or not for a first and then a second booster, and that's been super helpful for us to reinforce and to have people confident that our vaccination program is working. So next one, please. So this is just a summary of our vaccination history for COVID, right? And I'm gonna just focus on 3 or 4 milestones. So we started our mass vaccination campaign on February the 2nd, 2021. And although we used some Pfizer's vaccine we mostly used CoronaVac. At that time, the predominant variant was P1 or Gamma, and we vaccinated most than 80% of our population with 2 doses of CoronaVac separated by 4 weeks. Then you can jump into August 11 of the same year, 2021. And at that time, we were observing that even though cases were really low and our ICUs were in a good moment, we saw early signs of reduction of the. Sorry, there's a problem. I think the screen sharing is not working for anyone.
We can see the screen clearly, Dr. Fair.
You can see your
okay.
yeah.
Okay. So we saw, based on our real-world effectiveness assessment, we realized that vaccine effectiveness against symptomatic disease was clearly decreasing. So we decided to go for a fair booster campaign around 4 to 5 months after having completed the primary series of CoronaVac, and then we. And that was during Delta, right? So starting Delta outbreak, just right before the first cases came into the country. And then we finally are going to focus here on December the 6th last year, in which we started to use CoronaVac for the 3 to 5 years old group. Why this group is important? First, because children, young children are not very commonly studied, and also because this group was vaccinated just at the same time that we had our first cases of the Omicron variant. So all assessments that are focused here on this group in a way reflect the effectiveness or the performance of the CoronaVac vaccine against the Omicron variant. So it's important to think about that when I show you the data later. And finally, on February 14th this year, we started a second booster campaign, basically because we started to see the same decrease in effectiveness that we observed after the primary series. So we assumed that if we were to wait more time, we were, having a risk of having an increase in the use of the hospital network and more death. So we decided to go with a second booster, mainly heterologous at that time, but that was the reason for making it, for going forward. The next one, please. So how do we approach vaccine effectiveness? The next one. Early on, once we started to vaccinate people with CoronaVac on early 2021, we realized that we needed to be super fast in assessing the performance of the program in order to have people willing to receive vaccines and to correct or reinforce our decisions. So we work on this V-COVID cohort that with my group we implemented, and we built it up basically using already available information from different sources. And 80% of our population, this is not huge, but it's around 80% of the population is around 16 to 17 million people who were included in this cohort. And the cohort allows us to capture prospectively incident events, for example, COVID cases, new hospitalization, ICU admissions, or death, because everything is centralized, and the Ministry of Health is fed daily with all the new information that is arising from any part of the country. And we also have the immunization registry, which is also very well curated, so we can also have information regarding exposure to no vaccines, 1, 2, 3, 4, or any type of vaccine, almost in real time. So we have this cohort, and this is the basis for our analysis, and it allows us to basically run tests whenever we want. So we do it periodically. Next one, please. And this is an important paper that I was invited to write by Daniel Fakin and Minal Patel. And it doesn't have information regarding inactivated vaccines, but it's super important because it says that after 6 months, when you, after completed the primary series for infection and symptomatic disease, and also for hospitalization, it was clear that there was a decline in vaccine effectiveness, both for RNA vaccines and for viral vector vaccines. And the drop in effectiveness was around 20 to 30% for infection or symptomatic disease for all the vaccines, but it was around 10% for hospitalization at 6 months. So this was something that we were expecting to find, but it was super important for us and for many other countries to reassure that the first booster was highly needed. Next one, please. And now, I just want to show you an overview of this article that we published in Lancet Global Health that summarizes our findings on the performance of the first booster shot. So we have, we used homologous and heterologous booster shots, but I'm going to be focused here on the CoronaVac booster on top of primary series of CoronaVac. So let's say 0, 28, and then around 5 months after the second shot of CoronaVac, we used a third dose. And this group was mostly people around 70 to 75 years old. So it's a risky group, and it was important to look at. And in the table, you have to look at mainly 2 columns. This is when we have the outcomes: laboratory confirmed COVID-19, hospitalization due to COVID, ICU admission due to COVID, and death due to COVID, all the confirmed cases. And then we have the person days, so it's important to look at this, and numbers are huge. And then the number of cases, we saw a lot of events, and then the incident rates unadjusted. But then you have to jump in to the last column where you can see our adjust estimates for vaccine effectiveness. And why do I say adjust? Because in the model that we run, we include information regarding sex, age, comorbidities, and place of residency, income, etc. So this is the adjust model, and you have to focus here. So for when we analyze the effectiveness of the third dose of CoronaVac on top of 2 doses of CoronaVac, we saw that the booster was almost 80% effective to prevent laboratory confirmed COVID-19. It was 86% effective to prevent hospitalization, 92% effective to prevent ICU admission, and 86, almost 87% effective to prevent COVID death. And as you can see, the uncertainty was very decent and with very narrow confidence intervals. So this was super important for us in the country to show the people results and to make them, confident that third doses were important. And actually, we had a massive response, and most people in the country received any of the third doses that were available at the time. The next one, please. This is another paper, and the idea here is to show you the effectiveness of CoronaVac, which was the only vaccine that we used as primary series for the age group of 3 to 5 years old. And the importance of this paper is that it was conducted, the follow-up, almost exclusively with circulation of Omicron. So the period here in this color represent Omicron from our genomic surveillance. And as you can see here, since the end of the last year until the analysis that was initially on February 24, but we repeated later on, results are the same. The circulation was almost only Omicron. And then you can see here a similar table. Here you have the outcomes, and then you have vaccine effectiveness. And please focus here. The first thing that you can see is that effectiveness of 2 doses of Coronavac against symptomatic disease was 38%. And it might not look good, but if you think about the other vaccines available, numbers are that. I mean, either for mRNA vaccines in children and AstraZeneca's vaccine for adults, when you look at the effectiveness to prevent infection and to halt transmission, the effectiveness is really low for all vaccine available. So we have to focus now on the effectiveness against hospitalization and ICU admission. I am not showing death in this table because we only have 2 deaths in the unvaccinated group and no death among the vaccinated group, so there's no sense to look at the estimates. But as you can see here, effectiveness of 2 doses of Coronavac to prevent hospitalization in the 3 to 5 years old group was 65% and was almost 70% to prevent effective to prevent ICU intensive care admission. And these numbers are important because this group is a group that has a low baseline risk for being admitted to the ICU because they usually recover without any help, right? So for a vaccine to show an effect has to be super evident, the protective effect, because the low risk generate a bias that makes difficult to see an effect. So these, in the way we interpret this, were important numbers. And when we ran the same test 4 to 5 months after having initiated the vaccination program, effectiveness was still close to 60%. So, so it was good news for the rollout, and again, it helped us to reassure parents that at least the primary series was important, safe, and effective, even in the Omicron era. The next one, please. So, just the last slides to discuss. We are, as I said, we are rolling out second boosters for most of the population. We have vaccinated almost 80% of the eligible population with a second booster. We are analyzing results as we speak, so it's work in progress. The next one, please. But what I can tell you is that this is a plot that we actually people from the Ministry of Health developed to show when you look at the overall population and you try to see who's actively protected with an actively protected definition of having received a vaccine in the last 6 months, you can see that almost 10 million people in the country, so more than half of the country, received a 4th dose in the last 6 months. So we think that we have a good coverage, because when you add those that only have 3 doses, we have almost 100% of the population with either 3 or 4 doses, and with a growing rate of people with 4 doses. And when last words, sorry, when we ran our analysis 6 months after having received, after initiating the campaign for a 4th dose, we have a preliminary results that says that for ICU admission, any of the available alternatives for 4th doses or second boosters have an effectiveness of 73 to 80% for ICU admission, and from 79 to 90% for death. So again, the 4th dose seem to be really important and making an active role for controlling the pandemic. Now in Chile, we have around 10,000 cases daily, which is a good number. So we are in a surge. We have mainly BA4 and BA5. So we are having the surge that Dr. Ajit mentioned before. But the rate of admission to ICUs is really low. So we are seeing the effect also in the daily life. The last one, please. So what are the take-home messages that I want to share today? One is that we know that vaccine effectiveness wanes over protection, right? Vaccine effectiveness wanes over time. And also we know that new variants do emerge, and these new variants are able to, evade the immune system. So we need boosters. how many booster we need. The first one for sure. The second one, we use it for all the population, but there are countries that are selecting special groups, and that's okay. And the timing probably is 4 to 6 months, as Dr. Ajit also said. And we know also that inactivated vaccines are very robust against severe outcomes, were used as third doses, at least in our studies. Then we also know that CoronaVac was effective in preventing severe disease in children during the Omicron era. And finally, second boosters in this preliminary evaluation seem to provide strong protection against severe outcomes. So that's my last one. Thank you very much, and happy to answer any questions.
Thank you so much, Dr. Rafael. A very interesting clinical data from Chile to confirm that the vaccine, either homologous or heterologous, they are equally as good in terms of giving protection. But more importantly, during the outbreak of the Omicron, the same vaccine were able to give strong protection against among children. So that's very interesting. So I believe for the audience who has more questions, please type in. I will read it later for the panel to answer. Let's move on to hear more data on clinical from China, from Dr. Gao. Over to you, Dr. Gao.
Okay. Okay, so can you hear me now?
Yes, go ahead. Yes, Dr. Gao, we can hear you clearly. Please proceed.
Okay, but it cannot move. Please go ahead. Next one.
Next slide.
Okay, at first, just to echo what Dr. Ajay has mentioned. So globally, now as of August 7, it has been reported more than 500 million cases and more than 6 million deaths globally. And also Omicron variant remains the dominant variant circulating globally. So basically, this is a global background of the current situation. So next slide, please. So what I want to emphasize is that, next slide, please, is that among all those cases, in fact, the children cases and deaths cannot be ignored. So according to the report from WHO, sorry, previous one. Can we go back? Yes. In fact, this next slide, please. Next one. Yes, this one. Okay. So this graph just describes the case and death trends among children under 5 years old. So here you can see very clear, earlier this year or end of last year, there's an increase of death numbers, case numbers, which caused by Omicron variant. So that means Omicron surge has led to a higher number of COVID-19 cases, deaths, especially for the children under 5 years old. So it's very important to think about that we should protect children from Omicron variant. So next slide, please. So this graph describes the way we use to protect children and adolescents. So the blue line shows the people who have vaccinated with at least one primary series. And the black line shows that people or children, adolescents didn't get any vaccines. So here you can see very clear during the Omicron outbreak here, the people or the children, adolescents who have no vaccination has a higher risk, or 2.8 times higher risk of testing positive is compared to the people or to the children who have been vaccinated. So they here tell us that it's very important to get our children vaccinated against the Omicron outbreak or Omicron variant. So when we come to the vaccines, I would like to share some data of inactivated COVID-19 vaccine, CoronaVac. So next slide, please. So next slide, please. So this is a very simple design of phase 1, phase 2 clinical trial of inactivated vaccine among children. So it's focused on children between 3 to 17 years old. This has been started last year, and we have preliminary data to show the safety and the immunogenicity. Next slide, please. From the safety data, here we can see, next slide, please. 2 doses of CoronaVac have very good safety profile among 3 years to 17 years old. So the overall incidence of adverse reaction was about 20% to 30%. And most AR were grade 1 and grade 2. That's no grade 3 or 4 is mild adverse reaction. And the most common reaction were injection site pain and fever. So most importantly, I want to emphasize that no serious adverse reaction related to the vaccination. So this means 2 doses of CoronaVac when used among children between 3 to 17 years is very safe. Next slide, please. And also we can check the immunogenicity data. Next slide, please. So here the above graph shows the positive rate of 2 doses of CoronaVac when used in children. So over 96% of each group who received CoronaVac, 2 doses of CoronaVac, had developed antibodies against SARS-CoV-2 virus. And also the below graph shows the GMT of different dose of CoronaVac. So here you can see the standard dose, because the 3 microgram group was significantly higher than the lower dose group. And also these 2 graphs, whether it's a positive rate or GMT, shows that CoronaVac, 2 doses of CoronaVac induce humoral response in children between 3 to 17 years old. So next slide, please. So this result of 2 doses of CoronaVac among children. So next slide, please. Next slide shows that not only 2 doses of CoronaVac, if you give a 3rd dose, because it's both doses of CoronaVac among children between 3 to 17 years old, it also have very strong immune response. So neutralizing antibody against the wild type or original strain shows a more than 30-fold increase after the 3rd dose or both doses among children 3 to 7 years old. So the positive rate of neutralizing antibody among different groups were all 100%. If you compare to the peak of GMT in 28 days after 2nd dose, they are around 5 times increase. This means 3rd dose of CoronaVac among children has induced a very strong immune response. Next slide, please. Next slide, please. Okay, so here just 2 graphs to show that the different intervals between the 2nd dose and the 3rd dose can also induce a neutral immune response. So here you can see the severe conversation of a neutralizing antibody were 90% and also 91% for lower and middle dosage groups respectively. So that means whether it's a lower dose of 1.5 microgram or 3 microgram, all have a very high seroconversion. And for children between 3 to 5 years old age group, the positive rate of neutralizing antibody were 100%. So, and also there's a good cross neutralization against Omicron strain of a third dose of coronavirus among 3 to 70-year-olds. So this graph just emphasizes that it's used Omicron virus or Omicron strain to test the neutralizing antibody. So that means the third dose of coronavirus, when used as a booster dose among children between 3 to 70 years old, can induce very strong neutralizing antibodies against Omicron strain. Next slide, please. And also this data from Chile to show that just the data showed just as a third dose of coronavirus among children between 3 to 70 years old also have a good safety profile. So all ARs are grade 1, grade 2, so no serious AR reported. Next slide, please. Next slide, please. Okay, not only children, but also for adults, if they receive a third dose or both dose of coronavirus, you can also generate or induce a very strong immune response. Here you can see the neutralizing antibody level increase 20 times for adults between 18 and 59. Next slide, please. And also, again, this is another graph to show that different intervals between second dose and third dose can generate immune response. But if the interval is between 6 months, it can generate a higher, a more strong immune response. And the seropositive rate is about 90%. 90%. Okay, next slide, please. Okay, here just to see not only adult between 18 and 55, but also adult aged 60 years and older. They also have a higher GMT after they got a third dose or both dose. Next slide, please. Okay, this is a result of study from Chile to show that the coronavirus booster can induce immunogenicity and also showed a good cross-neutralizing effect against variant of concern. So after both doses of immunization, the seropositive rate for Omicron strain was over 75%. And the neutralizing antibodies and the SARS-CoV-2 specific T cells induced by both doses shows activity against variant of concern, including Delta strain and Omicron strain. Next slide, please. Okay, not only studies for immunology, but also we have real-world data, real-world evidence study to show the vaccine effectiveness or vaccine protection of 2 doses of coronavirus. So here is the results from a study conducted in Hong Kong. The study covered the period from January the 1st of this year to April 19th. So overall, there are almost 60,000 children aged 3 to 11 years old, and also 40,000 children or adolescents between 12 to 18 years old. So here it just compares the effectiveness for different doses of CoronaVac are also BioNTech or Comirnaty. So here I want to emphasize that in children or adolescents aged 12 to 18 years old, so the vaccine effectiveness for 3 doses is almost 92%. It's very high and a very solid evidence to show that 3 doses of CoronaVac work very well during Omicron outbreak in Hong Kong for children for adolescents between 12 to 18 years old. So next slide. So next slide, please. Here's another study conducted during the Omicron outbreak in Hong Kong. It covers the period end of last year, December 13th of 2021 to March 3rd, March 8th of this year. So it's also Omicron BA.2 as a predominant strain. So it also shows that 3 doses of both vaccines, CoronaVac or Comirnaty, offer very high protection against severe disease and mortality. And also 3 doses of CoronaVac provides over 90% protection against severe and fatal disease and mortality across all adult age groups. So this study focused on adults older than 20 years old. So this study focused on adult population to show that 3 doses of CoronaVac performs very well against serious disease caused by SARS-CoV-2. Next slide, please. So the last study I want to mention is a multi-center international phase 3 trial of CoronaVac, which focuses on children and adolescents between 6 months to 70 years old. This had been started last year in September. The objective is very clear to evaluate the efficacy of CoronaVac against symptomatic COVID-19 cases. And also is conducted in China, Chile, Malaysia, Kenya, South Africa, and Philippines. So next slide, please. I want to share some very preliminary data of this study, because this preliminary data shows that 2-dose CoronaVac in this phase 3 study have a very good safety and immunogenicity profile among children between 6 to 35 months. So in this study, or in this preliminary analysis, 202 children were enrolled who received at least 1 dose of CoronaVac was conducted for safety analysis. And also 170 children were randomized into vaccine group or placebo group for the neutralizing antibody level analysis. So the left graph shows that the safety profile of 202 children was very well, because if you see the total AR or adverse reaction or local AR or symptomatic adverse reaction, it's all around 20 to 30%, which is very common for a new vaccine. And for the grade of severity, it's all below grade 2 and no more grade 3 or grade 4. It means that almost no serious adverse reaction reported. The most common symptom, for example, fever or injection site pain, is not very high here. And also, if you look at the right one, is a GMT value of neutralizing antibody for the 171 volunteers. Here you can see 28 days after second dose among children between 6 to 35 months, the antibody level is very high after they complete the second dose. So for the right one, the right 2 yellow orange bar is indicates that the children before they get vaccinated, whether they have been infected or they have a positive antibody result. If they have a negative, here you can see it's a little lower if compared with the result before they get vaccinated. If they have a positive testing rate, that means they have been infected, and then they receive the 2 doses of CoronaVac. It's much higher than the previous one. But if in total, you can see the second orange bar is very clear that among children between 6 months to 35 months, there's a very strong immune response for this group of children. So next slide, please. Based on the result here, I mean, from the phase 3 study among 3 to 30 months children, so the preliminary result shows that 2 doses of CoronaVac among in this group, children group, have very good safety and immunogenicity profile. So based on this result, and also some local studies in Hong Kong, so Hong Kong authority extends the approval use of CoronaVac in children. So from 3 years to 6 months old for off-label use. So it's very encouraging news. That means CoronaVac have the opportunity to provide protection against Omicron variant for these young children, means the children between 6 months to 3 years old. So currently, as August 2nd, CoronaVac has been granted EUA in 14 countries or regions around the world. So here is this graph to show how the list of the countries or regions who have approved CoronaVac as a vaccine used for pediatric population. So next slide, please. So far, next slide, please. Next slide. Okay, so far in total, this is my last slide. There are 62 countries, regions, or international organizations have granted approval of CoronaVac as a EUA or conditional approval around the world. That means CoronaVac has been accepted by the international community as an important weapon to fight against the SARS-CoV-2 pandemic or CoronaVac pandemic, COVID-19 pandemic around the world. So this is also my last slide. I just want to emphasize that when we talking about the COVID-19 pandemic, we must think about the children, especially the children under 5 years old. So it's very important to develop an immunization schedule or strategy to protect this group of children against Omicron or any other SARS-CoV-2 virus in future. And also here I just showed some clinical data to support that 2 doses of CoronaVac or 3 doses of CoronaVac work very well to protect children, especially the young children, against the SARS-CoV-2 infection or virus. So that's what I want to share. Thank you.
Thank you so much, Dr. Gao, for very comprehensive clinical data to support and to confirm that CoronaVac is actually working in adults and children population. It survived against not only Wuhan, Delta, and now Omicron. I have a few questions from the audience here, but let me just first start my first question to Dr. Gao. Do you foresee the need of using different strain for your vaccine, like maybe Omicron strain?
Yes, we are developing Omicron-based vaccine, and also we are conducting clinical trial of Omicron-based vaccine in China and also in Hong Kong. So we are all waiting the results from this clinical trial.
Okay, thank you. The next question is for Dr. Rafael. How did Chile deal with vaccine hesitation?
It's a great question. So first, we didn't have a lot of hesitation at the beginning. Chile has a long story of successful vaccination campaigns, and I think it's the it's a unique example of how people can trust in authorities. So that's one thing. But of course, after but there's always one point in which you reach like the maximum compliance. And what we think it was important was to show results early. So having the cohort working and publishing the data in respected journals was key for having everyone on the same line. We are dealing today just after 3 doses, with the 4th dose in adults, with a bit more hesitancy, not due to a trust issue, but mostly due to a lower perception of risk that might be true, but we actually don't know. So we have a tremendous hybrid immunity due to natural infection and all the vaccines that we've received. So thinking that the disease is not a problem anymore, it is clearly a mistake. So we have a challenge there. But again, I think relying on scientific efforts, it's been successful for us, and I think that's a very good way to gain the trust of the public.
Thank you, Dr. Rafael. Yeah, getting trust by sharing data and being transparent. Perhaps the next question is related to Dr. Ajit. The take-up of the second booster dose in Malaysia is very low, especially since it has not been made compulsory. How important is this for the public to be boosted for the second time, Dr. Ajit?
We need to focus on the first booster before we go to the second booster. The substantial amount of population, both adults and elderly, are not boosted even with the first booster. Of course, people who have taken first booster, we are seeing the data coming from Chile and other countries that a second booster may be needed. Definitely needed for high-risk comorbid. Also, a booster is needed for, as we have seen the data coming from China, for adolescent population. What is happening with Omicron, especially B4, B5, they are with the increase in antibody level from the primary vaccination, we need to boost the entire population, including children as well. So my take would be we focus on the first booster for now for Malaysia, get the remaining population which is not boosted to get the vaccine, get approval for booster in adolescent, pediatric. And of course, if you ask me, fourth booster is needed. When and how, still there's a lot of research going on. And we will answer this question in a short while, maybe in a few months from now. But yeah, it probably is needed.
Okay, thank you, Dr. Ajit. That's very clear. Yeah, we have to focus on the first booster dose first. Okay, back to Dr. Rafael. One question related to the adverse effect in Malaysia was shingles. What was any adverse effect in Chile that you have observed?
Yeah, so first, I am not in charge of the adverse event surveillance, but we do have, very like open system for passive notification. So we are not centrally looking for adverse event, but we do have a really easy way for physicians and other healthcare workers to report adverse events. And when you look at the data that's publicly available, it's in Spanish, so it's not that easy for you, but it's there. And we always include a summary in each of the papers that we send out for publication. We haven't seen any red flag that's different from what's been published. So CoronaVac, it's clearly a super safe vaccine. and the other vaccines are also safe, but they do have the problems that we know for each of the vaccines. So no red flags or regarding different or particular adverse events or different rates.
Okay, excellent. Okay, back to Dr. Gao. The question is what is the possibility for our body to get COVID-19 virus and other viruses like monkeypox at the same time?
Sorry, I didn't catch the question.
The possibility of getting co-infection by both COVID-19 and monkeypox, what is the possibility at the same time?
Monkeypox.
Yeah.
So I think this is two type of virus. For COVID-19 is a respiratory virus. For monkeypox is usually a different transmission mode. So I don't know. Maybe in some countries or some regions, there's possibilities that there is a co-infection. As we know that WHO has announced an emergency response or emergency event for monkeypox, but it's not a common disease now in some area or countries. But there's some possibility, but I don't see it's a very high possibility, especially in our region.
Okay, that's very clear. Okay, again, Dr. Gao, there's a question related to the side effect. Some parents are concerned on having heterologous booster shot. What is your advice on this?
For booster shot,
yeah,
for children.
Yeah, primary
so
and booster dose, yeah.
Currently, it's based on our data, experimental data, focus on children between 3 to 70 years old. The safety or the safety profile has shown, or safety has shown that it's very good. So no need to worry about the safety issue of third dose of coronavac among children between 3 to 70 years old. And also for children between 6 months to 3 years, based on our preliminary data from phase 3 study I just mentioned or just shared, it's also very safe, just like the result for children and adults between 3 years and 70 years old. So for me, I think, just as Dr. Rafael mentioned, coronavac as an inactivated COVID-19 vaccine is very safe if compared with other type of vaccine.
All right. Okay, my question to Dr. Rafael. You presented quite a bit of data on heterologous and homologous vaccine usage in Chile, and the efficacy is equivalent, able to give good protection for both. What would be your advice? Whether should we stick to the homologous or we should try for heterologous? Because a lot of people, the concern on the perhaps safety, not so much on efficacy. Any comments on that?
Well, the short answer is I don't know, and I don't think anyone knows. But if I have to define or a public policy for vaccinating, I would continue favoring having a diverse matrix of vaccines, and not stick to any particular one, because we still have information to come. So in our experience, that has been a very useful approach. You can always you will always have people that for any reason cannot receive one or the other. There might be, as you said, adverse events that you are going to start seeing with more and more doses, and so that's my take. And we know now that homologous and heterologous schedule or regimens are comparable So I would feel more comfortable having at least 2 or 3 different platforms for vaccinating the population.
Okay, thank you. And Dr. Ajit, you presented quite a bit of data on the disease burden among children, and especially in Malaysia, the take-up is rather small. What will be your recommendation and advice to the parents?
Okay, so Dr. Bhatt, coming back to your earlier question about co-infection with infection like monkeypox or other infection, monkeypox is fairly new. We don't have many cases of that in Malaysia now. But in Malaysia, we are now seeing co-infection with respiratory syncytial virus, with influenza virus, and also with Mycoplasma pneumoniae. There are recent publications which say that this Omicron COVID strain is very friendly virus now, friendly with the other disease. So co-infection is happening, and we have to be very careful. So the parents' caution is to watch out for the symptoms. They may think that it's a flu because they got it from a flu infected child in the neighborhood, in the family, but it could be co-infected with COVID and flu and other viruses. So very careful about the symptoms. If a child is complaining of any symptom, lethargy, muscle ache, and if the child is not vaccinated, the recommendation is to get vaccinated. Especially in Malaysia, we have approved 5 to 11. Now, as you are aware, we are submitting new data from China to our NPRA here in Malaysia, which is under review. Once the approval is given for lower age in pediatric population, we will have to quickly vaccinate that population as well, which is below 5 years of age.
Right. Thank you, Dr. Ajit. Dr. Gao, perhaps any other new vaccine in the pipeline related to this from Sinovac?
For COVID-19, so we also try to develop many as more as we can to protect people's health. So not only Omicron-based vaccine, but also trivalent vaccine, COVID-19 vaccine are in our pipeline. So we are working on that. So, but we have priorities. First, we start from Omicron-based vaccine, COVID-19 vaccine, and we are try our best to push the process so we can get the result as
I think Dr. Gao frozen, Dr. Bhatt.
Yeah. Okay, we'll switch quickly to Dr. Rafael. Maybe Dr. Rafael, last words from you. Maybe how soon that we should get the 4th booster dose? Okay, Dr. Gao is back online. Maybe you want to finish, Dr. Gao.
Sorry, I'm sorry, lost the connection. Okay.
Yes.
Okay. Is there any new question for me?
Yeah, just if you want to just finish off your answer related to that.
Okay, I'm just trying to say that so far Omicron-based COVID-19 vaccine is our priority. We are put our effort on that. So we hope that in the future we can get a result for this Omicron-based vaccine. And also we are working on trivalent univalent vaccine.
Okay, thank you so much. Okay, now back to Dr. Rafael. Back to my earlier question on how soon should we get the next shot? Knowing that,
I think
yeah.
Looking at the lessons that we've learned, we rolled out the first booster around 4 to 5 months after the second one, or having completed the primary series, and that was during low COVID activity, and the Delta wave that came right after that was super mild in the country compared to other places. Now, if you see what happened with the 4th dose that was started 5 to 6 months after the 3rd and was rolled out during the Omicron outbreak. So we started the rollout with high disease activity. We had more death due to Omicron than what we were expecting to have, considering the degree of immunization that we thought we had. So although it's an ecological observation, and I cannot prove that from a causal point of view, I think we were a bit late in the fourth dose. So my recommendation is to go for it anywhere between 4 to 6 months, but when you have a good epidemic situation. So if you are around 4 or 5 and you have low disease activity, that's the right moment to receive the next wave with high neutralizing antibodies.
Yes, great. Any last advice from you, Dr. Ajit, before we close the session?
No, thank you, Dr. Wat, and I would like to thank the speakers from Chile and China. I think the last advice will be for Malaysia is to we get the boosters quickly. The children is a very precious population, which is only 50% vaccinated. If you look at from the number of children vaccinated, and we know the cases going high in 5 to 11, there could be co-infections. The ICU and the hospitals are receiving patients now in this age group, and this is very much can be prevented and protected. So my request will be for all the parents to go and get the vaccines for their kids. From our side, from Aniaga, we will try to register for lower age group, and once it is made available, we'll inform the media and the society so that we can offer protection to your age group as well.
Okay, thank you. Dr. Rafael, anything you want to close up with? Any advice?
Yeah, I think it is good to think about the next booster that might be coming, but I think it's wiser to focus on the stage that you are standing at. So if you are rolling out third doses or first booster, go for it, complete that, and then think about the fourth and so on.
Thank you. Very good advice. Dr. Gao.
Yes, just one word that Sinovac will always stand with you together to fight against the COVID-19 pandemic. So work together, we will win at last. Thank you.
Thank you so much to all panel. Very interesting webinar for today. We have seen a lot of clinical data to support that vaccine works regardless on the strain that we are facing. Especially the safety part, now that it's not only used in adult, but also used in pediatric as low as 3 and moving down to 6 months old. The solution is there. So protect ourselves, protect our family, stay safe. Thank you so much for listening. Thank you so much again. Bye-bye.
Okay. Thank you. Bye.